Welcome to Innersight, Health Optimization with Rudy and Shaun.
Well, here we go, Shaun. Another podcast, another month, and we've got some interesting, another interesting compound to deal with today. We're going to talk about the GLP-1 agonists. So, yeah, the two of them we've got in South Africa at the moment.
Yeah, I think after the last podcast with the creatine, then I think this one might even top that one with the interest.
Yeah, I mean, we're going to talk about a drug that's absolutely exploded over the world, and I think there's a lot of misinformation out there, a lot of possibly dangerous drugs that you should look out for, and I think the nice thing that we do, and we've actually brought some of the studies with today, is that we stick with the science. So we're not being paid by anyone. We're going to stick with the science, and we want to let people know what GLP-1 agonists are about. So, and I think maybe we should just say, I mean, they were developed for type 2 diabetes, but we're pretty much going to talk about them as a weight loss help in that sense.
Absolutely, and I think most people see it as a weight loss drug rather than a treatment for a diabetic person. But yes, we're going to talk about that, and that's on the radar today. But I think first we should talk about what is weight loss. What do we see as weight loss? So weight is a number on the scale, but that number represent a lot of things. It's muscle, bone, fat, water, everything together. So if you say you want to lose weight, what do you actually mean? I mean, we could amputate your leg and you could lose 20 kgs overnight, but that's not what you want. So weight loss is probably more, you want to look better. And when we say you want to look better, we probably refer to body composition.
Yeah. And I think that's what we have to get out there is body composition, weight loss. We're actually meaning fat loss. So and as we at Innersight, we actually think about the counterpart of that is that if you lose fat, you do not want to lose muscle, because muscle at the end of the day is actually one of the predictors. Your amount of muscle that you keep is one of the predictors of how long you will live.
Yeah, and I think that's one of the key things for a successful weight loss program is to lose as little as possible muscle and as much as possible fat. So it's so important to keep that lean muscle at all costs.
And that's where these drugs are quite interesting, is because they do in the studies seem to preserve muscle mass more than they shed the fat, so which is great. So
yeah, so I mean fat tissue. Why are we concerned about fat tissue? I mean, fat tissue is we as humans, we store fat, excess calories in the form of fat for times when we need it. These days we don't actually need it that often because we've got a supermarket around the corner, on every corner these days. But usually the fat that we store subcutaneously is not a problem. We're talking about visceral fat that we store around organs, because that's the fat that's metabolic active, the fat that causes inflammation, because it secrete or inflammatory substances, and that's what causes disease. So there's a couple of diseases that's increase with your visceral fat increase, and hence the health benefits of losing fat.
Yeah, and there's also quite a lot of toxins, your hormones that's stored in fat. So the more you lose of this visceral fat, the less you will be storing of these dangerous compounds. So, and obviously the one thing that's quite big on the radar is non-alcoholic fatty liver disease, which is a big part of why liver struggle is these days, is because people are too fat, visceral fat. So just for our listeners, what that means is inside fat. So that fat not the fat that sits on the outside, it's actually the inside around your organs fat. Yeah.
And hence also that it's not always just a number on the scale, because you get this skinny fat person, which is also dangerous, because I mean, what's even more dangerous, because you can't store the fat and the subcutaneous tissue, and everything goes to around the organs. So in essence, when we talk about weight loss, we're referring to fat loss. And if we refer to fat loss, especially fat around the visceral fat, the fat around all the organs, that's what we want to lose when we talk about weight loss. And we want to maintain lean body mass as much as possible.
Yeah, and I mean, before these drugs were around, there were a lot of other drugs that actually came in and out, and they had a lot worse side effect profile before that. But most of them either made you eat less or charged up your system to try and burn more. So, which is quite interesting, and that brings us to the calories in, calories out discussion. Maybe it's just to see where this GLP-1 fits in. Does it actually rev the system, or does it actually make you eat less? And it's quite an interesting discovery how they work.
Yeah, so I think with weight maintenance, as you mentioned, the calories in, calories out, I think we'll just do a very simplified version because there's much more to it. But basically on the calories outside, about 60 to 70% of your calorie burn as such is due to your basal metabolic rate. Okay. And basal,
meaning just being alive.
Just being alive, at rest, the amount of calories that you burn. And that is determined by body composition, and especially lean tissue. So that's why we come back here. That's why it's so important to maintain that lean muscle, because if 60 to 70% is determined by basic metabolic rate, and a big part of that is due to your muscle mass, it's important to keep muscle mass. Whenever you can't take the medication or you're off the medication, you need to keep that muscle mass. Otherwise, you can get that rebound effect because you've got less muscle, and then your rate will be down. Other factors is stuff like age, gender, and genetics in the basal metabolic rate. Exercise as such is not that big a part in the equation. It's only about 10-15%. I think if you're doing the Tour de France, it's different. But for the average Joe, the mere mortals like us, 10-15% that you get with exercise.
So it's actually quite little. So it then actually, like these drugs are showing us, it's more about the calories in, because the calories out, we can't control that much.
Absolutely. So on the inside is the amount of food that you take in, your portion size, what you eat, and stuff like that, and the hormones that make you hungry, and that's where the GLP-1 agonist plays a big role. But on the other side, it's not that big of a role. So that's more or less where it fits into that equation, on the simplified equation. There's other things involved with the calories in and out. There's a thermical effect of food that you eat and stuff like that. But we can maybe at another time, if we want to do something on weight loss specifically, we can go in more depth into that equation. But for now, I think what we need to understand is, like, on the calories outside, it's important to maintain that lean muscle mass. And on the calories inside, that is where we're going to get a lot of help with these new drugs that's around.
Yeah, it's quite. Let's not keep the listeners waiting too long. Then, so that's where this drug fits in. It actually helps you not to eat too much. So, which is its major effect. I mean, it's got loads of effects, and we're actually learning more and more, pretty much by the month now. So, I mean, there might be quite a few of our colleagues that's going to learn a bit out of this conversation. So. Pretty much in the late 60s, the first peptides were discovered, and it gained a lot of traction in the late 80s. So these peptides have been around for quite a while, but it's a difficult peptide to be around in the body for too long. It degrades quite quickly. And it was actually found in the saliva of one of the reptiles in America. They found the base compound that was actually the first exogenide, the bayeta, that was the first commercially FDA approved GLP-1.
But that's been around since, 2005?
Yeah. And didn't work that well until semaglutide came along. So semaglutide we'll talk about now, but that is pretty much for Ozempic, or for our listeners, that's Ozempic. That's the trade.
Wegovy, that we don't really see here.
Yeah, we don't have it here, but Wegovy. And then after that came Tirzepatide, or that we call Mounjaro. So we've had Mounjaro in South Africa since February. And maybe we should then say, so the GLP-1, the name for it is glucagon-like peptide 1 agonist. So what that means for our listeners is GLP-1 is a hormone that gets excreted inside the first part of your small bowel once you eat food. And this is an agonist for that receptor, or meaning it actually stimulates that receptor.
Yeah, so there's many receptors, and it's found all over the body, in the brain, in the heart, in the kidneys, in the lungs, and not just in the gut. And that explains some of the other effects of the drug, other than the weight loss and the glucose control. But mainly, yes, secreted in the gut, which then leads to the gastric emptying to be slower, and a decreased appetite, which is more on a central basis.
And maybe we should then say the GLP-1s is the semaglutide, but then in Mounjaro or Tirzepatide, you've actually got the GIP as well. So
yes,
I'm going to try and say it. So it's glucose dependent insulinotropic polypeptide 1. So that's and that's got an extra effect on inside the body, but it's also one of the incretin hormones. Yeah.
Yes, and it's probably why it's a little bit better. We'll talk about the effects just now, but it's probably why it's a little bit better, because it's actually acting on 2 receptors and not just the one, like we see with Ozempic.
Yeah. So when you eat something, it'll go down into your stomach, and then the first part of the duodenum, you will have the hormone excreted. And then that sends signals everywhere. But I think the main drive with this is it busts your hunger, number one. And then we've got the hormones that it also then stimulates or blocks. So we've got insulin and glucagon so it stimulates insulin and blocks glucagon.
Yeah, but insulin is only stimulated when there's glucose around. So that's one of the benefits, is that it doesn't really cause a low blood sugar, due to the fact that it only stimulates insulin secretion when you take food in. With the glucagon, it suppresses the glucagon. So glucagon, basically what it does, it releases the stored glucose in the form of glycogen and into glucose. So it just stops that process a little bit, so that the blood glucose doesn't go up. So it works on 2 sides of the equation there, to stabilize the blood glucose. But also the delayed gastric emptying is also helps, so that you don't get that spikes in the glucose, with the food stays longer in the stomach. So that also leans a little bit to the glucose control in that sense.
And that's almost like a handbrake on the rest of the system to go slower, and hence you also feel fuller for longer. So.
But on the downside, that's also the reason why people get some of the side effects, like that nausea. Well, nausea might be more central, but that full feeling, the constipation, sometimes a little bit of diarrhea, reflux. It's all due to that delayed emptying from the stomach. And from an anesthetics point of view, also that delayed emptying of the stomach can cause problems with general anesthetics and things like that. So we would like people to be off that drug in that period of time.
I mean, and it's so new that all this came in quite quickly. But I mean, when we talk about side effects, and I specifically want to go to one of the questions we've had on our Facebook pages. People say, but I've got so many side effects. Where does this all come from? So now I think the listeners can have a little bit of an understanding. It works in your gut, and that's why most of that side effects are in your digestive system. So as you say, there's a little bit of central acting as well. We probably should say it doesn't cross the brain, the blood-brain barrier, so it doesn't actually go into the brain itself, but it does stimulate the receptors inside the brain.
So the satiety and the decrease of appetite is probably all central driven factors. Then obviously also, one of the off-target effects that they talk about is that it might, help with using less alcohol, drug use and things like that. And it's probably that pleasure center that's affected centrally. And that's why also with food, you get a similar like reward system when you eat certain food. So that might be one of the effects centrally to help decrease you eating too much.
Yeah. And I think then one of the, because it was developed mostly for diabetics in the beginning, I mean, your downstream side effect is that, or effect would then be that you have a lower blood sugar, and that's, I mean, you don't see a lot of hypoglycemia on GLP-1s as such, but it is also one of the side effects that you have to look out for.
Yes. Especially if you're on other diabetic medication, I think then it becomes very important just to make sure that you don't go too low. If you're not on other diabetic medication and you purely use it just for weight control, I think most people probably have some degree of insulin resistance if they're overweight. I think we shouldn't use it for normal weight people just wants to lose 1 or 2 kilos over for the next wedding or something. So we're talking about people that's overweight with like weight-induced complication of health issues, or people that's obese. Okay, that's the population that we look at, and most of the obese people will have that insulin resistance, and it's unlikely that they'll get hypoglycemic.
Yeah, I agree, and maybe we should then say obese people. We should say. Maybe we look at BMIs 30 plus, and then looking to lose about 20% of your body weight, because I mean the data behind this is that if you compare the GLP-1s versus just exercise versus having a partial gastrectomy or bariatric surgery, I mean it looks good.
I think one of the big concerns initially was, how much weight you lose, or how much do you lose on each of these drugs? Okay, so we can compare that just now, but how much muscle you also lose in the process with any weight loss technique or program or whatever you do. There is, you'll lose weight, but you'll always lose a combination of fat and muscle. And I think, with the Ozempic, but actually it's the Wegovy, the studies was done with Wegovy at the 2.4 milligram dosage, lost about 15% of their body weight.
And that's over a year. Right?
Yeah,
that's 12 months.
Yeah, that's a long-term weight loss. But the problem there was that in that study, it showed that they almost lost 30 of the weight that they've lost. Almost 39% was lean muscle, which is not ideal. So, and that was the initial feeling when we started these medications, is that, that's a little bit of too much lean mass loss. With the Mounjaro, the study shows much, much better results. And that was done with a dosage of about 5 to 15 was the dose in between that they've used for the study. Showed more weight loss in the sense of 22.5% weight loss. But the big thing there was that in that study, it showed that the lean body mass loss was only about 18, 19%. And suddenly, that looks much better. So, I mean, these numbers, you need to put it in context. So if you do a normal low-calorie diet and you lose weight, you can lose up to 20 to 30% lean body mass in that part of the weight that you've lost. And compared to bariatric surgery, I mean, that's also about 25-30% lean mass loss. So Ozempic a little bit worse than calorie restriction or surgery, but Mounjaro seems to be better.
Yeah. Yeah, so Mounjaro, Tirzepatide again. So just to bring the two names together, and so looking at that, we should probably say that is people staying on it. So people coming off these drugs, we should probably also say a lot of them gained their weight back. So more than 2/3 of people gained most of the weight back if they stopped the medication.
Yes, exactly. So in the first year after stopping the medication, almost 2/3 of the weight you've lost is back on. But if you extend that to 2 years, the newest data that's released shows that you almost gain back all your weight.
Yeah, and I mean, anecdotally, we haven't seen that. We haven't been using or seeing or prescribing it long enough that we have seen people like completely relapsing. But it is quite interesting that with the Mounjaro, it looks like the weight loss is a better weight. So and someone asked me in the week about the Ozempic face that people talk about, and that's probably because it's a mix of muscle and fat that you lose, and not just fat.
Yeah, and I mean, initially you lose more weight in the beginning, like with any diet, and then you've got that sudden weight loss, and then you get the Ozempic phase. But over time, that corrects itself slightly, because in all these things, over time you'll lose the rest of the weight that goes off slower. So it takes some time to lose the rest of the weight. So your initial weight losses at the beginning that's what we see is probably
quite dramatic.
Yeah, quite dramatic. Compared to the overall weight loss over the period of time. But yes. So basically, that tells you that, or I suppose it's a question: should you be on this then lifelong? Because if you're going to stop the medication, then you're probably going to regain your weight. And I think that's why it's so important to do other stuff. Get your protein right. Make sure you get enough resistance training. Because remember when we said about the calories in, calories out, that basal metabolic rate is driven by the lean tissue. If you lose muscle mass and you stop this drug, that's just going to be a yo-yo effect.
Yeah. So you have to change your whole outlook on life when this is happening. Like most of the people that do have a longer term with calories in, calories out, their whole lifestyle has changed. So they're exercising, protein, that they change their whole wardrobe, that they don't go back to that. They change their lifestyle, especially smoking alcohol. I mean, those type of things make a big difference for the long term. And then the other part is maybe if you're on a higher doses, maybe to step down onto the lowest dose if you want to continue on the GLP-1s.
Yeah. Another thing is that a lot of people stop these drugs without being told to stop the drugs. And we're not sure why. Maybe most likely it's due to the cost, because it's the out-of-pocket expense in most of the cases. So they've looked at a couple of things, and they've noticed that around about after 2 years, there's a large percentage of people that have stopped the drugs without being told to stop it. And the reality is that when you start someone on these drugs, you might need to keep them on it long term. But in the back of your head, a lot of them is going to stop it on their own, or they might have side effects and you might need to stop this drug. So I think the game plan from day one should be to have other things in place in case you not need to stop the drug due to side effects, or in case they can't afford it anymore, or they don't want to be on the drug anymore. So hence again, the lifestyle interventions. And surely in our practice, when you come into our practice and you, shall I say, qualify for a drug like this, we do an in-body scan to start off with, see what your muscle mass where you stand on before we even start the drug. And we have a discussion on your lifestyle factors. And then we will commit. We want you to commit to a resistance training program before we will consider giving you the medication. And then obviously we'll need to follow up and make sure that we stay within certain parameters with your lean body mass to make sure that you don't lose too much there.
And that's the other part. There was quite a few questions about the side effects. So maybe we should just touch on the side effect profile of the two drugs. So again, we're comparing Ozempic with Mounjaro because that's what's available to us. And I think the one thing that stands out in the side effect profile is nausea. So nausea, about 50% of people on either of these drugs will have a form of nausea. Some people feel like death. Some people just feel a little bit of nausea in the background, especially on starting the dose. But it's a lot less in Mounjaro we've found than on the Ozempic side. So, and then obviously we've talked about the gastrointestinal bloating a little bit, constipation. We've talked about nausea. Yeah, so it's
yes, and I think also what we also do is we start very low with the dosage, and we take our time to push up the dosage just to try and avoid that. I think if you're going to go up too quickly, too soon, then the side effect profile just climbs through the roof. And then there's other stuff that you can try and do, like smaller meals and things like that, to try and reduce that full feeling and nausea. But yes, that's the most common side effect that what we see.
Yeah. We've also been asked about the psychiatric effects. We in our research, we haven't found very specific research.
Yeah, so that was that one large study that they've published now recently, 2024, about the increase in major depressive episodes and increase in anxiety and possible increase in suicidal ideas. Then there's other studies that doesn't show that. It is, so it's difficult to say it does definitely produce symptoms like that, but it's obviously something to look out for. And I think
that's why we should have a red light. I think maybe we should switch on the red light here for people that buy this stuff just at any online shop, or get it from someone at the gym, or buy it from a pharmacy online, but don't have anyone looking after you in the background.
I think that is absolutely wrong to do it that way. It's so important to have someone to look. You need to look at the lean tissue. You need to make sure if someone's got a history of a psychiatric illness, what's the support structure there? Will we pick it up if something goes wrong? I mean, sometimes people themselves won't realize that they're becoming depressed, or and then you might need to partner in, or if they've known with the psychiatrist, get them involved in the process. So buying it over the internet, I mean, first of all, you don't know what you're buying. Okay, you don't know where the product is coming from. Is it a clean product? Are you going to get infection? Is it actually Ozempic that you're buying? So no, you definitely need to work with someone that can have a broader view over how to manage you with these meds.
Yeah, and I think in our South African context, it's not as expensive as in the US, but it is quite a big outlay, especially if you start going to the bigger doses. But people should be aware that it's like any drug that you buy from someone that you don't know where it gets made, or it's imported from a country that's not regulated by our SARPA, so we feel that's a major red light about what is happening with this in South Africa at the moment.
Yeah, no, absolutely.
Maybe we should talk about the other good sides of the GLP-1. So we've talked about that you lose weight, but I mean, there's quite a few nice studies coming out now that it's probably good for your heart, for your brain, and I mean, in the longevity world that we live in at the moment, it looks like it's going to be one of those drugs that help for more than just weight loss.
Yeah, so it's always difficult to say the effects. I mean, there's no doubt about it. There's positive effects on cardiovascular disease. The studies are out there. Positive effects on dementia. And we can talk about that just now. The big question is it due to the weight loss? Is it due to the blood sugar control? If you give it to someone that's not overweight, will they see the same benefits from it? We don't know. We don't have the answers at this time. But the point being is if you are overweight or you're type 2 diabetic, it does improve the outcomes.
Yeah.
Independent. If it's weight loss or sugar control, then so be it. The outcomes is looking good.
And it's very much like the SGLT2 inhibitors, the other drugs that we use for diabetics. I mean, they also have now been shown to help with dementia and cardiac profiles. So I think our feeling is it's probably because of that whole, as we call it, the metabolic profile of a person turning the right way.
Absolutely. But if you go look at the dementia data, it seems that there's a much, with the GLP-1 agonists, there's almost a 50% decrease in dementia development in obese people on these medications. But if you use the SGLT drugs, which also corrects for blood sugar, they don't see the dementia effect. Yes, they also get the cardiovascular benefit. So on the dementia front, there might be something else going on there. But you don't see the same amount of weight loss with the SGLT inhibitor. So maybe it's a weight thing. We just don't know at this point in time what's actually causing that effect. But yet, the data looks very good.
Okay, let's make it a little bit more practical. So how does it look when you actually get the script from your doctor? I mean, if you get your script from the doctor for Ozempic, you're going to get a little pen and you walk out there and it's actually, you're almost like someone with type 1 that have to learn to use an insulin pen. So it's very much the same type of click system. And you go from a lower dose and depending how your doctor's prescribed it. So it's the pen. But then with the Mounjaro, you actually have to fiddle a little bit for us in South Africa. You have to have an insulin syringe. You have to draw up a certain amount. You have to work out the dose to make sure what your doctor prescribed. And then it's a subcutaneous injection. So which, if you want to say it like that, it's probably a side effect. You can have infection around the sites, pain around the site. So hence you need to move around and not inject in the same site every time. But not everyone can inject themselves.
Yeah, so it's exactly the same as with a diabetic. So we're fortunate we've got a sister in the clinic that can show people how to use it, or we can show them ourselves if we need to. But someone needs to show you how to use it. And obviously, someone needs to show you what's the correct dosage, how to use it. On a dosage, usually we start quite low, and like something like Ozempic, we'll start at 0.25 or 0.5 weekly, and then up it if needed. But if they do well on a certain dosage, we're not necessarily going to up that dose. We're going to probably keep them at that, even though I know the literature states that you need to go up to a certain level to get the maximum benefit on weight loss. But if people are doing well on a lower dose, we'll leave it there.
Yeah, and I think that's the key is don't push too high too quickly, because people do get side effects, and I think that's probably people that start and stop early is because of that nausea side effect. It does make people feel quite yucky.
I think the only problem sometimes that can happen with using the lower dose is that once you've opened it, there's actually like a shelf life or rack life on the medication. So you can run over that time period, and then it's that gray area of is it still safe to use it? Hopefully in future the manufacturers will allow us to use smaller dosages for longer, and just repackage it in such a way that you can.
Yeah, and I think maybe that brings us to the microdosing. So there's on most of the YouTube channels, they are now talk about microdosing. But if you microdose, you will run over the shelf life of either your pen or your ampule. So, and that becomes dangerous in itself, because you're fiddling with possible infection, possible contamination of your little ampule. So yeah, it's probably unwise to microdose. You need to go to the lowest dose that's prescribed, but not lower than that, and not more often than weekly.
Yeah. But we'll see. In future, we might have data on that. And as I said, maybe the manufacturers will bring out lower dosage options also.
And I think that's what we need to say here. I mean, the data has moved from November last year in the publications to we're doing this now in April of 2025. So, I mean, in 6 months, things change. And these drugs looks like they're becoming better, but things change. So we need to stay on top of this as we go further. Yeah.
Yeah, I mean, Tirzepatide was only got the FDA approval in 2022. So we only have like 3 years of data on it. So it's early days, and hence we don't have the cardiovascular data on Mounjaro yet, because it's not published. It's due to come out now this year sometime, and then we'll see. But compared to all the other benefits, I'm pretty sure that benefit will be there as well. No, we'll probably, hopefully in 6 months, we won't look back and say, oh, what nonsense did we talk?
No, I mean, and I think that's why we're doing this podcast, is we've been hearing and being asked about this so many times, and we had to go dig deep to try and understand everything that's happening now, because I mean we haven't been using it for more than a year yet. So I mean everything is changing, and I mean as the listeners can probably hear, the Mounjaro GLP-1 plus the GIP receptors looks like it's working better for our clients, and which is
so obviously we're sitting here now and we said that if you're going to stop the drug, you might gain all the weight. Okay, but then we sit with a drug like Mounjaro that we've got 3 years of data. Okay, so we at this point in time don't know what the data would show if you've been on it for 10 years. There's no data available. So obviously there's that concern in the back of your head. What we can say is what's available today. So for Mounjaro, the last 3 years, it all looks positive. For Ozempic, which is a little bit longer on the market, we've got more data on Ozempic and time-wise data, so that seems to be fine. And we'll need to, in a couple of years, we'll have even more data to say if it's safe to take it on in the long term. Term effects is just not known at this point in time.
Yeah, and the other side is there'll probably, or there are already, other modes of administration coming out. So there will be sublingual. There are going to be tablets, but obviously with tablets you've got the issue with it having to go through the gut, and you have to have the first pass effect in the liver. So, but that is coming. So, and at the moment you have to inject once a week, but maybe you'll have a sublingual tablet within the next 5 years that you can just pop under your tongue, and then you don't have the issue with the liver that churns up half of your GLP-1 and have the effects that you need.
No, I suppose that's also one of the downsides, is you need to keep it in a freezer, in the fridge, to keep it cool.
Yeah, so I had that question actually yesterday with a client, and she said, I'm traveling, and then we looked up. So you can actually, once opened, have it outside under 30 degrees for 21 days. So it doesn't have to stay the whole time, but before you open it has to be
so once opened, then you, in that time period, then you can say room temperature type of thing.
And again, we bring it back to the listeners. This is so new. Like, I mean, I hope that there are some colleagues listening to this, and that we've done the research for them. That most of the references that we've got are like 2022, 2024, 2021. It's all very new, and it's exciting. It's a very exciting drug, getting people to have a better lifestyle.
Yeah, so what's the contraindications to this? I think we just need to touch on who cannot take these drugs. So obviously if you had a reaction to the drugs, and it does happen, it's very rare, but you can have an allergic reaction to the medication, then you shouldn't take the medication. Then they've got the black box warning on some of the medication, which is for the thyroid cancers and the
Yeah, so and that comes from rat models, eh? So most of the rats, so
yes,
it's not really been in the humans that they've seen that thyroid cancer problem. Again, very new drug, but in the rat.
So mainly they've seen it in the rats, and it's a medullary cancer. Whereas in humans, we usually get the papillary or the follicular thyroid cancers, and not that medullary cancer. That's a very low percentage of cancers in thyroid in humans. Okay, so that's a very rat-specific thing.
Yeah.
A lot of people has been on these drugs for a couple of years now. We don't see a strong signal there, but that might change if you've been on it for 10 years. We don't know. That's the short answer. We don't know. So if there's a family history, or you have a personal history of some thyroid cancer, then we'll say, I'd rather stay clear of this.
And then obviously the little bit of the acts of pancreatitis. So obviously this drug acts on the pancreas, or the receptors that work with the pancreas. So pancreatitis, when it came out, it seemed like it was going to be a higher percentage, but it's less than 5%, I think, at the moment.
It's something to be aware of. I think also go low, go slow type of attitude will help not, prevent that a little bit. But yet again, it's not something that you want to buy over the internet. You need a physician to just keep an eye on you and make sure things goes right. And then, pancreas, sometimes a little bit gallbladder issues with these drugs.
And that's very much with everyone losing a lot of weight very quickly can have a problem with their gallbladder, and that falls in the same category. So, what we've seen is people lose somewhere between 1 and 2 kilograms of fat loss per week, which is quite sizable, but it's not massive. It's not like you're not going to drop 10 kgs in a month. That almost doesn't happen that quickly, but it does happen quick enough.
Yeah, and I just want to bring back the psychiatric effects, or what's mentioned in that study as well. We need to realize with any weight loss, independent if it's GLP-1 drugs, with just normal calorie restriction, that the body sees it as a stress response because you're getting in less calories. So there's a tendency towards anxiety and things like that with any form of diet. So I think one just need to keep that in mind as well, as you mentioned now with the gallbladder.
Yeah. I think we've covered most of what we wanted to say. We've I think maybe just to sum it up, it's an injectable drug at the moment, available through prescription by your doctor. Weekly injection, works on the gut. It seems to be working very well for our clients. Nausea is the one thing that you should expect. About half of our clients have got quite major side effects of nausea, so a little bit less in Mounjaro, and we didn't touch on that, but Mounjaro's got a little bit less of the GLP-1 and more of, or GIP, which Semaglutide or Ozempic is only GLP-1, which might show why that happens. And then you got to pick who to give it to give it to, and be monitored by a physician. Just make sure that someone looks after you.
Yeah, and I think we need to just keep in mind that we don't have long-term studies on these meds. We don't know for how long you'll tolerate the medication or can afford the medication. So we need to have a backup plan. So just to use only the drug to lose the weight is not, I don't think it's wise. I think we should use it in combination with correct diet, resistance training, make sure your protein intake is good enough. And hopefully then at some point, once you've instituted all those lifestyle changes and you need to go off the drug for whatever reason, that you are metabolic fit enough to maintain that weight loss.
Yeah. Good. No, I think we will maybe take some more questions on our social pages if someone wants to know more. But I think we've touched on this drug enough that people should be excited about this new horizon, and that this is a very new field. And please stick with someone that is up to date with what is happening, because it's changing so quickly.
Absolutely. And I think the change in my mind was that it's more dangerous to be overweight and metabolic unfit than using a drug like this. The comparison between the benefit-risk ratios, just at this point, according to the data available at this point in time, I think it's worth using it in the right person.
Agreed. And thank you for helping me reference this and getting all the right information that we could share it, because this is pure science. There was nothing in here that we are being paid for, and we just want to get it out there that it's probably good for the right patient.
Great.
Thank you.
Until next time.
Until next time.
Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.